Hi, it's Tony Clement here. I'm the host of Boom and Bust here at the News Forum, where all voices matter. And just by happenstance, I also happen to have been a former Ontario Minister of Health during the SARS outbreak and a former federal Minister of Health from 2006 to 2008 in the Harper government. Welcome to our session on transforming Canada's healthcare system post-COVID. As Troy mentioned, I'll be navigating this session, which will focus on how to reimagine healthcare in the wake of more government decision-making and command and control than has ever existed before. COVID has seen unprecedented state direction, but also demands for even more government involvement in long-term care facilities, hospitals, pharmaceuticals, and of course, how we live our lives. So this session draws from passionate experts in healthcare economics. Joanna Barron is Executive Director of the Canadian Constitution Foundation, a legal charity that defends constitutional liberties in courts of law and public opinion. Peter St. Onge is a Senior Fellow at the Montreal Economic Institute. And Walter Robinson is a public affairs professional with significant expertise and experience with Canada's pharmaceutical companies. Welcome to all of you, and let's start our session now. I want to ask this sort of general question based on my introduction first and foremost. Despite the government's predilection to, as I said, this command and control model, it is really innovation that holds out the most hope for healthcare, and certainly we've seen in the pandemic, it's innovation that has given us the vaccines that at least offers a partial way out. So I want to ask this question. I think I'm going to start with Walter. Can you please comment on how innovation in healthcare is the solution to our problems?
Well, thank you, Tony, and pleasure to be on this session. I think the innovation component of it obviously is the vaccines, it's the science. And as we're seeing, actually, the science is probably the easiest part of fighting the pandemic. The organization and the ordering and the wide-scale mass vaccination effort is tough. But even innovation can help there in better scheduling, decentralized approaches, and working with people who understand the Amazon economy. I think we need more thinkers and fewer generals at this point in time in the pandemic. And I think if you take a look not only at vaccines, but a lot of the coronary issues, the respiratory issues, it will be innovative medicines that help people, the long haulers, through this COVID space in the next year. And in the decades to come, we're going to see a lot of side effects from mental health to other physical ailments that we're going to look for medical technologies, pharmaceutical technologies, and even big data, the Microsofts, the Google Healths, they're in this space as well. And we're going to need to work with them. The challenge that our healthcare system, Tony, has, I think, is that it's still a hospital-driven 1950s acute institutional paradigm. And when you try and put on new innovation on a system that's 50 to 70 years old, that's really tough. There's no receptor capacity, or it's very tough to do that. So that's something we need to think going forward with federal and provincial and even local public health officials working in partnership with industry and patients. That's missing, and I want to touch a bit on that later.
Peter St. Onge, I'm going to want you to comment on this as well from the Montreal Economic Institute. What role does innovation play?
Yeah, for sure. I mean, Walter made a couple of very important points there. I think in a sense what we've seen here is that a number of critical care industries really in Canada are sort of held together by string and chewing gum. Whether we're talking the healthcare system or the senior care system, they've been shot through with shortages, with various really scandals. People waiting long times in senior centers. They don't have enough staff to cook food, so the seniors eat their food once it's cold. Really things that you wouldn't expect to see in a country as developed as Canada. Now, in normal times, those sort of get papered over. I mean, certainly they're in the press, but they sort of don't reach this catastrophic level. And what happened here with COVID now is that these two very vulnerable systems, sort of threadbare systems, collapsed. It has been an enormous scandal. And indeed, that's something that we've tried to stress throughout this, is that it's not a question of pointing fingers. It's not specific people, whether they're policymakers or whomever. we're not looking to point fingers. What we're talking about is these are structural defects that all of us have been talking about for decades and decades. That is what we need the conversation to go to, is to use this opportunity and make the best of it for all the human tragedy and ask, how can we change the system?
Joanna, obviously from your perspective, I'd love to get your views on this as well.
Yeah, I was going to say, I was looking at examples from Israel where they had things like stethoscopes with live video cameras to transmit information of patients back to their doctors. In the US, there's been drone technology to drop off supplies to hospitals. And in theory, there's no reason why we shouldn't have these things in Canada. We have a highly educated workforce. We have extraordinary talent. The problem is that we have the seeds, but we don't have the soil in which to plant these seeds of innovation for them to flourish. Why? Because we have a government monopoly on healthcare. As Walter mentioned, it's a 1950s style hospital version of medicine. The only innovation to note has been the advent of telemedicine, which is not exactly cutting edge, but we have seen widespread adoption of it, I think from about 11% to 46%. Of course, telemedicine has inherent limitations, but I totally agree with the comments so far that we need to look at the bigger picture. And I hope that this crisis will wake us up to the underlying structural deficiencies we're dealing with in this country.
So, Jen, I'm going to stick with you. I'll ask our other panelists in due course as well. But I'm going to play this role-playing question for you. So, imagine yourself as the Minister of Health, let's say for the whole country, and you want to prevent another pandemic. What sorts of things do you think we need to do that? Joanna, you got the first shot at this.
I don't think that I could say. It's certainly not my area of expertise. I don't know if we know how we could have prevented this pandemic, but I will say that I would look at things like our ICU and hospital capacity running at 80 to 90% during non-pandemic times. I would look at what the actual crisis plan would be in the event of a pandemic, and I would look at the unfeasibility of running our healthcare system the way that it is, knowing what we know about the number of Canadians that already avail themselves of private options by going abroad. And I would just look at the coming aging population. I would say something fundamental has to change, even if it means killing our sacred cow, our public healthcare monopoly, I should say.
Walter Robinson, I know you well enough to know that probably at some point in your mind, you would have said to yourself, I can do better than the Minister of Health on this file. So I'm going to give the whole mantle to you. What would you do to prevent another pandemic?
I actually said it this morning on Twitter. I probably didn't every day since this started. But first of all, I have a great empathy for all ministers, as the two prime ministers said earlier today. This is uncharted territory for sure. I'll pick up on Joanna's comments. I think what I would do if I were the health minister, I would go to the prime minister and the industry minister and the finance minister and say, let's live to our 2015 rhetoric and look at a whole of government approach of how we approach healthcare, how we can figure out how to navigate Section 91 and 92, because it is a shared national jurisdiction. And the framers of the Constitution could have never seen global pathogens getting on an airplane and circulating half the planet 12 and 18 hours later. And we would build to work with industry and unions and providers and patients and say, where did we go wrong? What did we do well? And how can we build for the future on data? How can we ensure around hospital beds that this will have a cost? We were running it just in time in many respects for one of the lower OECD nations in beds per capita, in ICUs per capita. So we need to think about our healthcare system not only as being there for when you're sick, but look at it as insurance, however you do it. And I believe in public governance as opposed to public administration of our healthcare system, like many European countries have a best mix of public and private provision. And then as in turn, also look at our healthcare system and understand it is a national security interest. And most importantly, we're spending, I don't know, is it 20%, 10% of our GDP on it, or 12 to 14%? It can be an economic generator for us. And let's look at it that way holistically. That's what I would do to have a different approach to healthcare than just at provision delivery. Think about it as insurance for the future. Think about it on a population health paradigm, and really have a different discussion with all stakeholders. And think about it's our number one national expenditure. I can count on maybe two hands the number of journalists who actually cover this sector in depth. We need to rethink about how we provide critical acclaim and critical perceptions and constructive criticism on the healthcare system as well.
Peter, last word to you on this question. Anyway, you're the Honourable Minister of Health. You hail from the province of Quebec, but you're representing the entire country. What would you do?
Well, we did do a paper on this early in the pandemic, and we looked at best practices specifically in countries like Taiwan or Korea. There were certain things that might have helped, screening travelers, quarantining only people who were infected, but doing that much more diligently than we did. PPE manufacturing, so Taiwan within a matter of months went from essentially no domestic PPE to nearly actually more than self-sufficient. It was exporting them. So there are certain things that could have been done. But I think that really the key there, if we're looking towards the future, is that sort of quarantining the only infected. What that specifically means is focusing our resources where the need was. That, I think, especially in Quebec, is where we really went wrong. All right. So, for example, a lot of resources, a lot of government attention was paid towards generalized lockdowns, towards sort of shutting down construction workers, for example, right? This was a group who was not at high risk during the pandemic. The resources, the attention, even the money that was paid out to those younger workers, had that been dedicated to hospitals, to senior centers, right? These are enormous sums of money. We could have conceivably, by focusing our resources where the need actually was, we may have saved many more lives than we did in fact. We saw this most dramatically in Quebec, where because of shortages in hospitals, seniors were then ejected to senior homes, which were also understaffed. They were prepping for COVID. It was a complete disaster. Again, the money that went towards generalized lockdowns, in retrospect, of course, is 2020 hindsight, but that money should really have gone for the next time. Perhaps we can agree ahead of time that money should go to where the actual need is.
I just want to comment on your last point, because this is one of the things that's been frustrating for me as an observer. If the billions and billions of dollars of cost of lockdown, and I understand the reasoning behind it from our public health officials, but give the health minister $1 billion to build more hospital capacity. $1 billion per province you could even do. And that would be less cost to deal with the ICU cases that need to be dealt with, make sure people are safe and are recovering. Far less than the cost of generalized lockdown. That's the kind of economic trade-off that would have been nice to have that discussion about. Is that the kind of thing you're speaking of, Peter?
That's exactly right, Tony.
Yeah. Well, I'm going to keep with you for our next segment, because, and this is about kind of drilling down on some of the things you've already mentioned, some of the things I said off the top. Obviously, when we're looking at the narrative, and I want you to comment on this, Peter, the narrative of others who are commenting on the future of the healthcare system, they've honed in on, we've got to nationalize all long-term care facilities. That those should all be publicly run, and not only publicly funded, but publicly run. Hospitals, there has to be more command and control of our hospital system in order to deal with this. So you're at the Montreal Economic Institute. I know that is a competition and choice, researcher in our political climate. Tell us what the counter narrative has to be, because this is becoming the settled wisdom that more command and control in our healthcare system is necessary. So please comment on that, Peter.
Right. So Walter mentioned early that universal systems in Europe have private participation. They have much larger roles, both for private insurers and also for private providers. And, we did a comparison of different countries. There's something called surge capacity, which is when you very quickly ramp up your healthcare capacity. Usually this is used for things like airplane crashes, mass casualty. However, that process was used really worldwide. It was used in Canada as well, The results in Canada were pathetic. Generally, the rule was about a 1/3 increase over the first several months of the pandemic. In other countries, you saw 2 to 3-fold increases. And a big reason for that, for example, we zoomed in on Sweden, which obviously had a huge need for increased capacity. And big reason for that was private participation. So they could bring in many more resources in. Those resources were much more agile. So that's sort of the starting point, is that Canada's response has been fairly unique. It has been quite awful. For a country that is this rich, it has been quite awful. And so when we dig into that, what else is quite unique about Canada is that it has far more than other universal systems. We're not talking about the US, we're talking about Europe here, universal care systems where the government pays for all medically necessary care. In those systems, Canada is obscenely expensive. It also has among the longest waiting times. When you put those two together, when you have a system that is uniquely expensive and uniquely unresponsive to the needs of the patients, that only happens in one thing in this world, and that is when it is run by bureaucrats who are not responsive to the patient outcomes. How does that happen? Because government is running it. The thread of feedback from the individual patient to the actual budget process is so remote. There's almost no incentive for organizations, whether it's hospitals or senior care centers. The individual people certainly care about their patients. There's no question. That's why people get into healthcare. But the organizational incentives are such that you have very little effort or terrible outcomes in terms of responding to what the actual patient needs are.
So do you see that there can be a decent argument to be made that more bureaucratization and command and control is not the way to go?
Oh, absolutely. Whether it's Singapore or Sweden, all the system that we looked at had extremely decentralized decision making. Individual administrators in hospitals, they could decide budgets. The budgets are typically attached to the patient, so it's automatic funding. They don't have to go hat in cap to politicians to try to get more money. Moreover, they can make things like staffing decisions, right? They can reroute money from something that they don't need at the moment to something that is most urgent. They can act like a manager of any private business might, so that they can respond in a more flexible manner to what patients need. That is exactly what our system ran into, is that you have all of these bureaucratic processes, and so the patient is languishing while bureaucratic turf wars go on.
Walter, Joanna, now's your chance to jump in on this. Do either of you want to say something on this one?
Go ahead, Joanna.
Oh, I was waiting for you. I'll wait to talk about our private healthcare case, which will bring in a lot of these concerns that Peter has so ably raised.
No,
and Tony,
yeah, sure.
Tony, I just pick up on Peter's point around the decentralization. It's something to think about when we think about healthcare. We think about hospitals. We think about big, multi-billion-dollar facilities, the stuff that's up and down University Avenue, or a Jewish General in the SHU in Montreal, Tom Baker in Calgary. We should really be thinking as well about the 9,000 to 11,000 pharmacies, how you define those as great locuses of community care and primary care. The 80% of the healthcare that we consume throughout our lives, the 20% usually at end of life, or if we have some rare disease or we're stricken with a disease state. That's where we need to focus, and in that space. And I think COVID and telemedicine have really, as we heard today, COVID has accelerated and brought a lot of technological adoption forward much faster than 5 or 10 years. It's on our doorstep. We're using it today. We've all grown up watching the Brady Bunch. Now we're part of an episode of the Brady Bunch on these screens as we network. And so that's where we need to go. We need to decentralize that in primary care and really push that care out into the community. And that will be a mix of public, private, and third-party non-governmental organization providers in a publicly governed system. That's where you can, because healthcare is high tech, but it is fundamentally high touch as well.
Well, speaking of which, that's a great entree for Joanna to talk about what her experience has been on the day case and what the status of that is. Maybe tell our audience a little bit more about that case and where it stands now, and how that animates some of your assessments of what our healthcare system is like right now. Joanna, it's all yours.
Sure. So I'll say first, part of why the reason that we're pursuing this issue of the right for individuals to take their health into their own hands when government waiting lists fail them is because polling has consistently shown, and in fact, increasingly shown. We did a poll, National Leger poll just 2 months ago, that said a majority of Canadians in every province support a right to private health insurance or right to private health care. And so the issue is not, unfortunately, public support. I mean, that's part of it. But the issue really is, stubborn bureaucracy in governments and basically people being terrified of admitting the elephant in the room, that there's a huge generational problem. So having said that, this litigation, which is brought by the Canby Surgery Center and Dr. Brian Day in Vancouver, has been ongoing for more than 10 years. It's been supported by the Canadian Constitution Foundation. It culminated in a trial decision, or I shouldn't say culminated, but we had a trial decision of the BC Supreme Court last September in which the trial judge sided with the government, and a few points on why. So our constitutional challenge to provisions of the BC Medicare Protection Act, which essentially prevents physicians who work in the public system from taking on any private clients, even though many of them, because of government rationing, don't even get enough operating days to fulfill their professional qualifications. So there's no issue of them overextending themselves in the private sphere. And so whether those provisions violate Section 7, the right to life, liberty, and security of the person, and Section 15 of the Charter, the right to equality. The judge decided that they didn't, that the government's objective of preserving the sanctity, essentially, of the public healthcare system justified the effect on the individual patient plaintiffs. And my overall commentary on the case is that it's impossible not to notice the tremendous deference on the one hand to the government and their stated objectives, as well as the lack of scrutiny if less invasive measures would be sufficient, for example, to say, as in many other countries, and of course, as my colleagues have noted, most other countries have some form of public-private hybrid. Canada is an outlier in this sense. Even we learned recently, even communist China has private healthcare options, but also the United States is an outlier in this sense. So bringing up the US as a comparator is not appropriate. It's the only major wealthy country that does not have a public healthcare system. So he very much deferred to the government's rationales. And at the same time, he tremendously minimized the pain and suffering of not just the patients who are plaintiffs in our case, but the thousands of patients who are evidence demonstrated were waiting beyond universally accepted maximum medical wait times. We've found that in some public health units in BC, in the Vancouver area, more than 75% of patients exceeded wait times. So in any event, our view as constitutional lawyers is that this interpretation of Section 7, which is a right that has been interpreted by the Supreme Court of Canada in the last few years to extend to the right to work out of a brothel and higher security, the right to access a safe injection site, the right, of course, to access a physician-assisted suicide. So it's quite an expansive right, that this decision was simply not at odds with the dominant line of case law. And so we're looking forward to the appeals. I should mention we also won an injunction late last year against the BC government, against them enforcing these provisions against private clinics, which have operated in BC for over 20 years, over 30 years, in fact, with no appreciable effects on the public care system. So all of these fears that allowing some release valve of private care are really more hypothetical, really more fantasies than apparent. So our injunction was won, and I'll have something to say about that later, because I think it relates to what BC has done with their surgical backlog occasioned by the pandemic. And our appeal will be heard at the BC Court of Appeal in June. And we expect, of course, that it will end up at the Supreme Court of Canada, which has a precedent in Quebec, the Chaouli case, which found that a similar provision in Quebec was unconstitutional. So we certainly hope that they will stay in precedent with that line of case law.
So I've got to ask you, Joanna, because all of this, all of our context right now is COVID. That's the big elephant in the room, I guess, on a lot of this as well. So do you think that COVID, and as I talked about, people's understanding of the healthcare system, obviously how important it is to us for our own lives and liberty, to be alive. I'm not sure about the liberty part, but at least we're alive if it does function well. Do you think that COVID helps your case, or in some manner does that hurt your case?
I think it overwhelmingly helps. As I mentioned, our polling showed a noticeable shift towards a preference for some private option that we conducted the polling in February, so it was specifically posed in the context of COVID. I think that when the judge came to make our injunction decision, it was first of all so unseemly for the government to be seeking to shut down private surgical clinics during a pandemic and inevitably reduce people's ability to access healthcare. But I think the unsustainability, for example, I'm in Toronto in Ontario, as some of you are as well. And we are a province of almost 15 million people, all under a stay-at-home order because under 600 individuals are in the ICU. It simply is unsustainable. And we understand the reason for that. And of course, it's not just the beds, we know it's also the staffing, but the reason for that is because of government rationing. It just doesn't work. It just doesn't have the agility and flexibility that we need in order to meet extraordinary situations like this.
Walter Robinson, I'm just going to shift gears and give you a chance to talk about the life sciences sector and how can we have a more coherent policy on life sciences, and specifically, although not just on this issue of intellectual property, but that's a key notion, I know. So why don't you tell us a little bit about that sector?
Well, I think life sciences is a broad description. I would kind of human health sciences or life sciences. Let's remember, around the world, the most R&D intensive industry on the planet is not oil and gas, it's not IT, it is healthcare. That is the place where you have the most innovation and the most patents being filed and the most work that's being done in research. And we need to admit as a country, from Trudeau Sr. to Trudeau Jr., inclusive of conservative and liberal administrations, we have not really had a national life science policy across that whole of government: health, wealth, national security interest. And again, you have to work with the provinces and local providers. What we can see is that we have a lot of the building blocks there. I think the greatest accomplishment of the Chrétien government was the institute, or bringing in the Canadian Institutes of Health Research, these multidisciplinary institutes, even above balancing the budget, which is now a model to drive public-private partnerships in health research around the planet. We have great researchers. We lead the world per capita in peer-reviewed medical research, but we can't commercialize and transform that because we don't have the receptor capacity and the environment of proper intellectual property protections. Cole Pinto, the CEO of Pfizer Canada, testified before the Health Committee just a few weeks ago. He called our IP environment mediocre. And what I would hope that our federal government does is accord life sciences, medical devices, pharmaceutical, and other kind of innovators in that space the same protections that they're driving for artists in our copyright policy, in our oil and gas sector, in our forestry sector, in our natural resources, and the new things that we're doing in animation and aerospace. The government seems to have focus on IP there, but disregards it in the context of court decisions in the pharmaceutical and life sciences world. And the other thing I would say is you need other supports around policy and procurement. The sector is not looking for any sort of subsidies or any of that nature, but policies and procurement. The up and down University Avenue and in university labs across this country, we have companies that have great ideas, but they could never get reimbursement in Canada. There was no problem of a drug or a device, so you can't run a clinical trial on it in the country. It's unethical to do so, to bring something to patients and then take it away, so they go elsewhere. Sean Silkoff had a great article in the National Post a couple of weeks ago, how Canadian minds are leading some of these major global enterprises in the States and around the world because there was no receptor capacity or true opportunity to flourish here in Canada. So that's what we need to do. I will offer credit where credit is due. When you were health minister, we had some data protection regulations, and under the Mulroney government, the PMPRB. And the last thing we need to do is stop pursuing policies for 1981. Pharmacare is like the fax machine of Canadian healthcare policy. We're in the world of personalized medicine where everybody gets a or they should get a full genomic workup to figure out what your gene mutation is in oncology or rheumatoid arthritis or rare diseases. And we need to really think about patients, especially at the center. Every company says it, every manufacturer says it, every government says it, but we don't do it. And one more point on that. Yeah. We talk about lived experience for Indigenous relations, for substance abuse, substance addiction. We need to have lived experience with patients at the center of building our Canadian healthcare policy as well.
So I could go a lot of different ways with that, but maybe I'll just ask this question to Peter. Look, it looks like, I'm not here pasting the mission accomplished sign on the aircraft carrier, but it looks like the silver lining to this terrible, tragic situation that we find ourselves in is the amazing ability of pharma to come up with a vaccine in record time. And if that continues to be the story, if it continues to be safe and effective, eventually gets us herd immunity, that's an amazing thing to have happen in a year's time. The only part of the healthcare system that actually worked better than anticipated. So all of that kind of happened, or most of it, I should say, happened outside Canada. What are your thoughts on that, Peter?
Well, absolutely. Pharma gets attacked so frequently, people forget at the enormous social benefit that pharma derives. Lives saved. And specifically, there are sort of two elements of pharma spending. One of them, so there's something called the offset effect. But the offset effect means that if you treat a condition using a drug that is typically something like 5 times cheaper, often far, far higher. Anyway, it's 5 times cheaper than treating it in a hospital. Okay, now pair that with a second little data point, which is that new drugs are about 4 times cheaper than older drugs. We have this on our site. I was going to cite it, but anyway, I'll just refer people. Anyway, so new drugs are 4 times cheaper. Drugs are 5 times cheaper than hospitals. You put those together, and what we should be doing is overpaying pharma. We should be, right? So what currently happens is that because government is on the hook for a lot of pharma spending, and also, it's appealing to newspaper readers to say, we're going to make everything cheaper. And so that is good politics. It's understandable to make it cheap to the patient. Okay, but there has to be something in the background that has to keep pharmaceuticals incentivized to continue inventing new drugs, but specifically to make sure those drugs are available to Canada, to make sure that hospitals are incentivized to treat people with drugs rather than other technologies like surgery that could be far, far more expensive. So honestly, if we're looking for patient comfort, if we're looking for value for our buck, we should not be looking at ways to reduce spending on pharma. Paradoxically, we should be brainstorming how to spend more. Keep it free or keep it cheap for the patient, sure, which is, the vast majority of Canadians already have health insurance for their pharmaceuticals. It's not broke. Don't screw that up. But broadly speaking, we should be brainstorming how to spend more money on pharma so we can spend less money on hospital care, on surgeries, and have less misery of, the patients having to live with their condition because the older drug doesn't work as well as the newer drug.
We've got time for one more question and one more segment, so I'm going to throw this one to Joanna first. Hopefully we'll have time for all of you to respond, but in your research for this court case, Joanna, are there any model jurisdictions or things we can learn, maybe from a particular province or from a particular other jurisdiction, that Canada should be looking at for the future?
Well, I think one interesting case is the surgical backlog in BC, and BC is actually a success story. Initially, I think in April of last year, the health minister had said it could take up to 2 years to clear the surgical backlog. They actually cleared 90% of it between late May, when things started to resume, and early this year. And they did that first by, of course, allocating about $250 million, ordering new MRI machines, things like that. But they also did it by outsourcing to the private clinics, which exist particularly in the Vancouver area, because of the release valve that was permitted to operate for many years until the BC NDP government started cracking down on them. When you look at other provinces, like Ontario, for example, at the Canadian Constitution Foundation, we filed a Freedom of Information request last fall where we found some very disturbing numbers that 75% of pediatric surgeries had been canceled and had not been caught up. Of course, pediatric surgeries should not be delayed. 74% of other surgeries, 30% of oncology surgeries. So I think it shows that when you do have a release valve, even if the government has a somewhat bipolar way of talking about them by trying to shut them down in the courts on the one hand and then outsourcing them to the other, but that flexibility clearly worked very effectively in BC.
Walter Robinson, any lessons to be learned out there?
I think the lessons to be learned are for all of us, wherever you stand on the healthcare divide, more public, more private, greater participation, is we need to change the narrative and how we look at it. We continue to look at, COVID has helped us do this. Public officials all the talk, we invested this billion here and that billion there. What did we buy for? Let's not talk about the prices and inputs. Let's talk about the outputs, because we're investing a lot of money and the virus is still going to virus and there's a lot of misery still to come. So let's take a look at, can we control the epidemic of cancer in this country? 100,000 people have died over the space of COVID. Can we look and figure out how we invest and actually improve Indigenous health? And that's going to take all stakeholders at the table. Let's measure the outputs and then figure out, not say we should limit spending here. Perhaps you want to spend more on interventions or salaries or drugs or whatever the case may be. If I'm getting better outputs and I'm getting a more productive and a growing economy and raising equities and inequality, that's a good output. Let's drive more investment into that.
Peter, I'm going to unfortunately cut you off at 30 seconds, but you've got 30 seconds for your great vision.
Okay, very quickly, I was going to mention earlier, Joanna mentioned telemedicine, that had been liberalized. I think that's sort of a metaphor for what we need here, okay? Public opinion has loved telemedicine forever, but it was running up against special interests within healthcare. I think that what we need to do is push through the special interests. We need to put more emphasis on patient-centric care, make reforms that actually benefit patients. We need to dethrone the special interests that have blocked a lot of this innovation.
That's all we have time for today, but a great session. I just want to thank Peter and Joanna and Walter for an amazing discussion. Lots more to be said about this topic. Hopefully we can revisit it next year at the next Canada Strong and Free Network conference.